All right. Well, hey, everybody. Welcome to episode number 4 of the Great White, not the Great, I always say the Great White Shark. It's the Great Blue Shark. I'm your host, Chris Hopper, and today joining me is Dr. Audra Cook. She is the founder of Magnolia Direct Family Care. Kind of a little short story on how Dr. Cook and I got acquainted. I've got a client in Ada, Oklahoma, Vision Bank. And Vision Bank, what's it been, 2 years ago now, Audra? One?
Almost exactly 2 years.
Almost exactly 2 years. Christy, that runs the HR down there, said, man, I've heard this thing, direct primary care. I think it'd be great to provide that to the employees. What do you think? I said, Christy, it's a great idea. And she's like, hey, do you know Dr. Audra Cook? I said, no. I said, but I know she's a DPC, direct primary care. She's got to be good because that's in the DNA of the DPC. So great to have you here today, Dr. Cook. First question, what got you into healthcare?
Well, yeah, thanks for having me on this.
Yes.
And man, I wish I had a good story, an interesting story, but I was one of those kids that just always knew I wanted to be a doctor. And
Wow.
I loved science and I loved helping people, from a little girl. Like I remember people asking, what do you want to do when you grow up? Always a doctor. Now, what's funny is I got into college and got into interested in art, and I got interested in psychology and, kind of went off different ways and thought I might want to be a counselor or a therapist. And I actually had a psychology professor who told me, if you have any interest in medicine, since you have such an aptitude for science, please go into medicine. Please go. She said, we need people who love mental health and, appreciate psychology. Please go into that. And, the rest was history.
Right.
And the creativity and, the psychology are probably some of the biggest components of my practice.
Absolutely. Absolutely.
Yeah.
I mean, people have, and, psychology and just overall behavior probably causes a lot of the wellness or illness that somebody has. So you not only have to be a psychologist, but you got to be a doctor. You got to figure out what's wrong.
Yeah. And I have to be creative in figuring out, that like problems rarely present themselves in textbook fashion.
Right.
I joke with patients that, hey, you didn't read the manual. This isn't how it's supposed to look. So, yeah, thinking outside the box, those are all skills that have really served me well.
So you graduate, you know what you're going to be since day one, and, just kind of fine-tuned everything. Now you're a doctor. Now, what happened then? So you graduated from, where'd you graduate from?
Well, I went to OU College of Medicine for med school. I got my ND from College of Medicine, and then I did my family medicine residency at OU as well.
Yep.
And I graduated, finished that in 2005, and actually went and worked in Duncan, Oklahoma.
Okay.
I worked I joined a practice, a small practice there, and did the full spectrum, resuscitated babies and newborn nursery and nursing home, inpatient, did all of it. And I had my first baby, and he was about 6 weeks early, and I had to go on bed rest before, and I was in kind of an expense sharing arrangement at the time, meaning I wasn't employed. I didn't have a guaranteed paycheck. And then when I came back from maternity leave, I owed, and actually didn't take a paycheck for about 4 months after that. So I looked for an employment opportunity there because I knew we wanted to expand our family. And at that time, Duncan just wasn't, all of the doctors were independent. They all had their own practices. So there wasn't really a precedent or a place to be employed.
Yeah.
So I had a friend from residency who had joined at Norman Regional as an employed physician, and she wanted me to come work with her. So I went and did that for about 7 years. I worked for Norman Regional. It had a great practice. Then my husband is from the Ada area and wanted to be back, closer to his family. And we had 3 boys that, we wanted to be kind of from a small town. We like the small town feel, raising them in a small town. So I moved back to Ada and I worked for Mercy. So I worked for a health system here. And
So
as an employed physician.
whenever you started, let me get this straight. So when you started, you was down in Duncan, and most all the doctors down there, they're still independent. They're not working for a Duncan Regional or a Mercy or something like that. Because I think, most people, if I wasn't in the benefits space, I would be none the wiser, because so you've got independent physicians out there that still see patients on a regular basis, and then you've got what I call health complexes. I mean, so the Mercies, the Saints, the Norman Regional, a lot of those hospital systems have ended up buying up doctors' practices, such as, like some of the independent ones down there. Is that kind of right? Am I thinking right?
Yes,
Okay,
absolutely. There's been a big movement towards that. And I think, gosh, I've seen statistics recently, and I want to say that 80% of primary care physicians are employed as opposed to being having their own practice.
Wow.
As compared to the opposite, 20% of physicians were employed, maybe 20 years ago. So yeah, the climate, the culture of medicine has really, primary care specifically, has really changed.
Now, when you went to school originally, you've been going to be a doctor ever since you was a little girl. Did you think that you was going to work for yourself, or did you want to work for a big hospital system?
I didn't think of anything. I just envisioned myself seeing patients and taking care of people and saving lives. And,
yeah, right.
I didn't really think of all the logistics. When I was in med school, we have to do different rotations. And one of the rotations that's required for all medical students is called a rural rotation. And that's where you're paired with a physician usually a family physician from one of the smaller towns. And I was in Weatherford. And that is really where I fell in love with family medicine. I went and I was invited into this physician's home, into his family, went to Little League games. I loved that he would see a kid for a well child, and the grandma that brought him in, he would say, well, here, how's your blood pressure while you're here?
Yeah.
I really loved that kind of full spectrum family medicine, what we call cradle to grave.
Yeah, and
I thought
that's what I always hear from, doctors. Once they say, you know what, I became a direct primary care and went out on my own because it let me do what I got into this industry to do, was take care of people, love people. I mean, just listen to people. But that's got to be a big step. So you was working for somebody, had a baby, didn't have a paycheck, and now I owe a lot of money. I want to expand my family. So now I'm going to go back to where I can get a paycheck. And I do that for a while now. I say, you know what? That's it. I want to go out and I want to be an entrepreneur. I'm going to be a DPC, and DPC it's DPC. And you go into a small town. Was you the first direct primary care down in Ada?
I am. And to kind of back up. So really the pandemic, I was involved in some leadership position when the pandemic hit, and was grateful to have the matrix and the infrastructure of what a larger health system was able to offer. We had guaranteed paychecks. We had we had kind of the basic safety. They were coming up with all of these policies to keep us safe and keep patients safe in those really early, scary days of the pandemic. And, there was very much a sense of, okay, don't worry about it. Do what you do. Do what you have to do. We'll figure out the rest later. And it it was quite a financial impact. I mean, as with everybody, but particularly with a lot of these larger health systems, they took such a hit, such an impact, that eventually they did have to say, okay, we've got to figure out how to start kind of recouping some of these costs. And well-intending, they came up with some different strategies, and one of them was population health, which is basically how to take really good care of a larger population of people. And through refining that and having that come to fruition, it put a rift between the physician-patient relationship. It really put a big divide. I felt like it really compromised it, because it became kind of more about, the doctor with the most patients under their panel is going to thrive in this type of system. And, some of your best doctors were ones that valued spending time with their patients, and really not that everybody didn't, not that every physician didn't, but I feel like there was really a push to that. And I felt burnout. I got burnout, and I lost control over just kind of some common sense practices in my clinic and workflows, and I felt like I kind of became a cog in a wheel.
No. So go ahead.
Well, so I started exploring. Well, I was looking at going to another clinic here in town. There's some other employment opportunities, and I explored those, and really kind of felt like I was I'd be jumping from the frying pan into the fire doing it. So I kind of heard about direct primary care through different some of the social network sites, some of my social network groups, other physician groups. And the consensus was really, okay, this is what's going to save medicine. Physicians, we have to take back our power, and we've got to we've got to be the ones to bring bring that back, bring those clinics back, bring that patient relationship back. So
you can spend more time with the patient when they come in, instead of just, they've been waiting in the lobby for 45 minutes. Doctor comes in and says, "Hey, Chris, how you doing, man? Good to see you. How's the family? What else is going on? What'd you come here to see me about? I got this hurt on my knee. Oh, okay, yeah. I don't have that much time." So that's the stories that I hear. Is they just rush you.
Yes, and some of the larger health systems are going to a team-based approach, where you may have a nurse practitioner or a PA, and they can be part of your team, which is great in theory. But I had 2,500 patients to my panel alone, and at my busiest I had 4,000. So I had a PA and a nurse practitioner. So I had 4,000 patients that called me their doctor, that identified me as their physician, and I would run into people that would say, "Well, yeah, you're my doctor," and I wouldn't recognize them.
Yeah, man, how you do it?
And it wasn't right. It did not. That was not why I went into medicine. It felt fundamentally wrong.
Right. Yeah. So you want to have a relationship with your patients. You want to know them.
Yes.
So you can spend time with them.
And along those lines, I want to be able to spend time with them, and I want to know them and know their history, but I also want to be accessible to them when they need me.
Yeah. So
I know I would always cringe when I would hear one of my patients having to go to urgent care, and I actually had a patient that was had been fairly healthy, and kind of saw them once a year and for routine stuff, and they had come in and they had lost about 30 pounds, that completely unrecognizable. And I asked them, what had gone on, and they said, "Well, I had COVID. I was in the ICU for 6 weeks." And I had no idea. I had absolutely no idea. And they said, "My spouse called the office and told them." You never heard? No, I was in the hospital, and when I tried to get a follow-up, I couldn't, so I had to go back to urgent care. I went to urgent care for my follow-ups because I couldn't get in to see you.
Goodness.
And that happened twice. They had to go to urgent care twice. And I just, that was really kind of one of the last straws for me. I thought, no, I don't.
Oh, that was still when you were still at the
That was still
hospital.
when I was at Mercy.
Oh my goodness. Yeah. That's so that's a tough deal. So if you were gonna, well, I don't know if that system can, I mean, we could sit here and try to figure out, hey, how do we fix the hospital, physician system? Or, you could do what you did. You can just break out on your own and say, listen, I'm going to start a practice to where I can do what I got into this business. And my passion is taking care of people.
Yeah.
So how do you build walk me through, if I'm a new patient, if you're building a relationship or a file with me, if I get accepted as one of your members, into your DPC, walk me through what happens from when I don't know you, you don't know me, until our meeting, and then that relationship starts. What do you want to know?
Well, so most patients, will complete the enrollment online. So that populates a chart, and we get an email. Our staff, actually myself, and then my assistant will get an email notification, and immediately we will reach out to them, like within several hours, within almost always same day. We will make an attempt to reach out to the patient by phone, email, text, whatever. We reach out to them just to welcome them, and we'll see what they need. I would love to offer same day visits for new patients. That doesn't always work out that way, but if it is something urgent, then we try to accommodate that. So, a lot of times, gosh, I had somebody who enrolled Friday, and we were able to get them taken care of today. So, the turnaround time, we really try to accommodate people and meet them where they are. What do they need? Do you need a follow-up within a week? We'll try to figure something out. Do you need a follow-up in 3 weeks? Do you need a follow-up on a Tuesday between 9:30 and 10 on the third moon? I mean, we could really, we try to accommodate what people need. So we will call and schedule. And I think that's a huge, pro or plus of my practice, is how quickly we're able to get new patients in. You call any primary care clinic around here, and you're going to wait to see anybody for at least a few weeks, probably more like a couple of months for a routine thing.
It's
I've even had situations where somebody called and said, hey, I don't need to get in for routine stuff for another few weeks, but I've got a rash. Can you look at my rash? So we really try to kind of look at it from the patient's perspective. What would we want? What would we expect? And so we strive towards good customer service. We're a good clinic, or I'm a good doctor, a good practice, but we also try to be good customer service, and we want to be friendly. We want to be a welcoming place. That we want this to be a medical home.
Well, and that's there's a whole lot of I'm not going to say transparent, but there's a whole lot of misalignment in this industry as a whole, and I caught myself in the same type of a situation. I'm a part of a direct. I'm a member of a direct primary care arrangement up here in Edmond, and my wife had been as part of them one for like 3 years prior to me joining it. And I mean, she's a nurse down, and at the time she was at St. Anthony's. And when I talked her into getting a direct primary care relationship, she had a kind of a adverse lab, and she was concerned about it. It was on her annual physical, as she should be, and she called her primary care or her OB, whatever it was, and they was like, it's not nothing to worry about. I mean, let's check something in 6 months. And she was like, well, I am kind of worried about it, and I don't want to wait 6 months. And I told her, I was like, listen, I've got a friend, he's a DPC. I said, he's got a clinic up here. I said, why don't you go in and talk to one of their nurses or doctors, a PA, whatever, because just like what you're doing. I said, because they will they want to know what's going on. It's not just hey, get you in here for 15 minutes and leave. They're going to talk to you. They're going to go through your medicines. They're going to go through what's ailing you, what's troubling you, and then assess and see, hey, do we need to change anything, or is everything good? And so she goes, listen, I've got access to doctors. I don't need that. And I said, you know what? Humor me. I'm going to pay for it regardless. So you just go. And you know what she said, Dr. Cook? She said, after that one deal, she goes, I wish I would have done this 10 years ago. She said, you know what? Michelle listened to me, and she's going to change this and do this and do this. She said, you should join yourself. And I was like, I don't go to the doctor. I don't need to go. So fast forward 3 years, I'm at a conference. I cannot quit coughing. I mean, I had drank cough medicine. So finally I called Michelle. I was like, listen, I got to get in. I said, I don't know what's going on. I don't know if I need a shot, whatever. So become a member, go see him. And then it's just like, hey, next time I need the doctor, I don't even call. I just text, say, hey, I need this. And they go, okay, you need to come in, or I need to do this, or I'm going to call you in. And it's like, before, all of our patients would try to do that. Well, the way the system was set up, they had to go see him in order for the doctor to get paid. And it makes it easy probably on you, but on the member too. How do you go ahead?
And I literally had at least 3 people in between my patients and me when I was in a larger health system. I had, whoever answered the phone, and then I usually had there was a triage nurse or somebody. Then there would be my nurse, and sometimes there was a fill-in nurse. So if a patient called and needed something, be it a med refill or had a med question, it would be filtered through all of those different people, and they were all doing their job. I mean, they were all good, great people, but
yeah,
it was the system. It was how it was set up to be, and a lot of that never got to me. Or it didn't. Think of the worst game of telephone. What the patient was most concerned about did not make that to me, or the nurse would be dismissed or invalidated, or we don't have time, or we'll call you back in an hour or two, and they wouldn't get a call back for ever, maybe.
Absolutely. So this question here, it's going to be about marketing, and how do you market yourself, your practice as a family physician, and where does most of your business come from? Is it word of mouth? Are you out knocking on doors, social media, what? Because now you got your own clinic, you got to do your own deal, but now you got to market too. That's got to be a balance. That's got to be a juggling act.
Yes. That's been the biggest challenge of all this, because I'm not a self-promoter. And I think I'm inherently uncomfortable talking about myself and promoting myself. So it's used a different part of my brain. I have been lucky in that I haven't had to market aggressively. I had, with such a large panel, and kind of the common thinking is, about when you transition from a full fee-for-service practice to a DPC practice, about 10% of your practice will come with you, and that's pretty much what I observed.
Okay.
So right off, I had a kind of a good solid base of people. Mm-hmm. Not everybody that I thought would come over did, and people that I didn't expect did. So word of mouth has been critical for me, and really just as Dr. Kyle Rickner says, spread the good word of DPC.
Yep.
People telling their friends and having good experiences, and then sharing oh my gosh, I can't believe I've had this with a spouse the other day. The wife had signed up, had been my patient for a year, and she called me on a Saturday, and she's like, I'm so sorry to bother you. I have this cough. I've got this going on. What do you think? And I gave some recommendations, called her in something. Well, then her husband enrolled the next week, and he said he came in to establish his appointment. Yeah. And he laughed and he said, "Here I'm calling. I can't even call my office to think about getting a phone call. Getting an appointment with my primary care provider. And my wife already has a prescription in hand by close of business on Saturday."
Yeah.
He said, so it was a done deal.
It's an easy decision once you get thrown into that mix. I mean,
once you see it
in action.
It's like having a doctor in the family. That's what another patient had told me once. It's like having a doctor. I feel like I can call you.
Well, and what I've seen with businesses from our agency as we help businesses and set up. In fact, we're working with an oil field company. They hired a doctor to be their in-house, direct primary care. They're like a $700 or $800 under employees, and so they just brought it in house to do this because they wanted their members to have access, and that's the biggest challenge from our side. Seeing, when we go to chat with companies about direct primary care, is the first thing they say is like, all right, what does it cost? How do I implement it into what I'm doing now? And most of the time, that's where the disconnect is. It is an extra expense initially, but the fact that you guys can basically bring healthcare to them when they need it, and not any more than they need, not any more, not any less, but it'll help drive those costs down. But most of the plans out there, they're just not customized enough to take advantage, to see that windfall and from the economics, but from just a true, is a DPC an absolute game changer? I think so, because now you've got access and you can help stop some of the bad things that might happen, or at least guide and direct people to good quality care. What's your thoughts on that?
Oh, absolutely. And not to mention the employee satisfaction component. Just to offer this, like, hey, we have this is our health insurance offering, or this is our disability insurance offering. And by the way, we have a relationship with this direct primary care clinic. So you can go access them whenever. You can text them on a Monday morning if you have a sore throat, and you can get taken care of with them by the end of the day, or sometimes by noon, by lunch. I think it's just such a good thing to offer. And yes, with me having a smaller patient panel, I'm really able to mind the store. I'm able to really, when I'm face to face with somebody and can talk through their symptoms, a lot of times I can keep them out of the ER. I've had people text me or call me in the evening and, hey, gosh, I have this. Do I need to go to the ER, or can this wait? Oh, it can wait. Come on by and we'll take care of it first thing in the morning. I'll meet you at the clinic at 8. I can sew things up. There's so much that I can do, and I can be a good steward when I have more time, which I do in this model, that I can sit down with them, like, what is in the best interest of your health. Obviously my patient, the patient is the most important thing, but what financially is important too. Patients want to be good stewards. And if they have a high deductible plan, or if they don't really understand their insurance plan, they want to be included. They want to have discussions on, okay, are we going to go see this specialist? How much is this going to cost? How much is this going to cost? And people want to engage in those conversations, and they value transparency, cost transparency.
Here's a specialist conversation. So, like I said, I was a part of a DPC, Dr. Rickner's practice up here in Edmond. And I went down there to that. I got my cough taken care of, and my wife said, hey, there's a new dermatologist in town. You need to, she switched whatever hospital she was working for from Saints to Mercy, and she's like, hey, you need to. And I think these guys are taking on patients. So I go up there. It's a nice facility. They get me in, get me out, blah, 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 burn some stuff off my face. And I think I paid them $100 copay to get in. And then I paid them, so much for the burning the stuff off, and so much for something else. By the time I got out of there, it probably cost me $400. And I was like, man, that's kind of crazy. $400. And then I was at a conference, FMMA conference up in Kansas City, saw Dr. Keith Smith, Jay Kempton, all that stuff. And I was talking to one of the DPC guys up there, and I was like, man, I just spent $400 at a dermatologist. I said, can you guys do that at your DP? He goes, we do it all day, Chris. He goes, I don't know why you didn't think about it. And I was like, I don't either. I could have saved myself money because the primary care doctor can do most of all the stuff that a person needs.
Yeah. I did it while talking to somebody about their blood pressure today.
Right.
They had a little spot. They were like, hey, what do you think of this? Well, I think it probably needs to be frozen off. You want me to do it?
Yeah.
And that was all included in the fee.
Yeah, it's part of the deal.
While we were talking about there.
Yeah. Another thing that I heard about DPC is you guys dispense some medicines that are real cost savings oftentimes versus just going to the pharmacy. Is that right?
It is. It is. We can, in the state of Oklahoma, physicians can dispense non-controlled medications. So, I have contracts, as many DPC clinics, we have contracts with wholesale medication suppliers and can get those at cost. And then we have, a lot of us just haven't just enough to cover, like our bottles and things. Markup, that's what I'm thinking.
Yeah.
So it's
very
negligible. We can do that for really affordable.
So if I'm hearing this right, a DPC relationship, it's really not a cost. It's almost, it's a savings mechanism, because you can have access to the doctor. They're going to steer you the right way. They're going to listen to your problems. That all sounds great. What is one of the biggest challenges in business that you're looking to improve this next year?
I would say expanding my social media presence. I would like to market a little bit more and expand on businesses. I'm involved in the community, and I have conversations with business owners that are interested and say, gosh, or maybe they're members and we have a great relationship, and they always say, oh man, we need to get to lunch. We need to talk about pairing with what could you do for my business? And it's like the idea, the interest is there, the idea is there, but connecting the dots, that's something that, I know that that's a process, but that's something I'd really like to work on, and, kind of implementing those.
So just getting the word out to the businesses, social, however that is, just kind of letting people know that you're available, and a little bit more about DPC. That's great. Where can people find out more about you today?
Well, so my website is www.magnoliadirectfamilycare.com.
Okay.
All one word, Magnolia Direct Family Care. But you can also call us at 580-722-5400. And my assistant Sally, or myself, or my nurse Leah, one of us will answer the phone, and we'd love to talk to you about it. We'd love to have have people come over and see the clinic and visit with us about what we can offer. We've got a good thing.
That's great. Well, and we'll try to drive some folks your way. Hey, Dr. Cook, thanks for joining me today, and thanks everybody for tuning in. If you got any questions you'd like to answered by the Great Blue Shark, feel free to reach out to me on LinkedIn, and I'll have the link in the description. If you like this episode, don't forget to subscribe, follow, and leave us a 5-star rating, of course, on Apple Podcasts and Spotify to help us get more Great Blue Sharks to come share their story and advice. Dr. Cook, thank you so much for joining us. Loved your story. Wish you all the best, and we're going to try to get down to Ada and help promote the Magnolia Direct Primary Care and send some business your way, and just tell the story and how great of a service. So look forward to working with you in this next year, and thanks again for joining us on the podcast.